Good afternoon, ladies and gentlemen. The conference will begin in 5 minutes. Good morning, everyone. I was told I said afternoon before, so my apologies. I've been up for a while today, so it certainly feels like afternoon to me. Welcome to the CMS 2017 Medicare Advantage and Prescription Drug Plan Fall Conference. My name is Stacey Plizga, and I will be your moderator for the conference today. This morning we are gathered here in the CMS Central Office Auditorium in Baltimore, Maryland, where the webcast is originating from. We have a number of CMS subject matter experts and sponsors who will provide important new information for Medicare Advantage and Prescription Drug Plan sponsoring organizations, CMS staff, and other CMS partners. Throughout the day, we will learn about existing Medicare policies, new policies, policy updates, and technology updates. CMS experts will provide an understanding of enrollment and eligibility, as well as how to fight fraud and abuse within the Medicare program. We would like to recognize all of our in-house and our webcast viewers today who are joining us from all across the United States. We have more than 4,000 joining us today between in-house and webcast, so we're very excited about that. Thank you to everyone for joining us for this important event. We also recognize that there are many individuals who were unable to join us today, and our thoughts are with all of those who are recovering from Hurricane Harvey in Texas, and all of those who have already been impacted or may be impacted by Hurricane Irma. Next slide, please. Next slide, please. Before we get started, I would like to review with you a few logistical elements that may be helpful throughout the day. Helps if I turn on the slide advancer. Okay, materials. Webcast materials are available at the CTEO website that is listed on the screen. So if you have not done so, you can go there and download the presentations to follow along today. If you are with us here and were unable to download them, there are copies outside the auditorium doors. Continuing education credits are also available for the event today, so you can go to the CTEO website to get information on obtaining those credits. There we go. Technical support. If you are having technical difficulties, we have staff members who are available to assist you. Please use the email box CTEO tech support at cms.hhs.gov for your technical questions or concerns. Please remember using an Ethernet connection versus Wi-Fi and Google Chrome instead of Internet Explorer may increase your webcast streaming speed and prevent any delays. The Medicare Advantage and Prescription Drug Plan Fall Conference and webcast will feature interactive polling today. And this will allow you to evaluate sessions and also participate in the presentations. There are a number of ways that you can participate, and the first is you can respond to polling questions via text message using your cell phone, or you can respond from any smartphone, computer, tablet, iPad using the web address for the software. If you would like to participate in polling, and we certainly encourage everybody to do so, both our in-house guests and our webcast viewers, you must first join my session. So let's do this together. We're going to get everybody joined up, and then you will be set for the rest of the day. If you would like to join via text message, take out your cell phone, select your text message, and then you're going to create a new message, and then you will type 22333 into the recipient box. Next, you will type CMS 2017 Fall. This is not case sensitive. please do not put any spaces between the letters or numbers into the message, and then go ahead and hit send. You should receive a message back that you have joined the CMS 2017 Fall Session. Okay, if you did not get that message, then you may have done something incorrectly, and please try again. But you are all set then. Okay, to enter your response using your cell phone text message, you will simply enter your response by responding each time a poll is conducted by entering the letter that corresponds to your answer, and then hit send. Okay, we also have end of session evaluations, which are just slightly different from the polling questions. When responding to an end of session evaluation question, when you are prompted by the moderator, you will enter A in response to the question, I would like to evaluate this session. You will receive a text back, and it says, hello, please evaluate this session. And it will provide you with a link. If you click on that link, that will take you to the Poll Everywhere site, and then you hit start. And once you click start, then you will be presented with the questions one by one. Select next when you're finished with that question, and then after the 4 questions, you will hit finish. And that will submit your answers. If you would rather join Poll Everywhere via computer, tablet, or smartphone using the web browser, again, you must first join my session. To do this, please go to www.pollev.com/CMS 2017 Fall. You should see a page like the one here on the screen, and it tells you that the polling is not in session right now, but when a poll is active, that will show on the screen. To enter your response using your computer or tablet, once the poll is activated, you will simply click on the answer that corresponds with your question. Okay, the end of session evaluation questions. When prompted by the moderator again, you are going to select yes to the question, I would like to evaluate this session. You will be presented with a link at the top of the screen in green. You will then click on that link, and then it will take you to the survey. You will choose Start Survey. You will be presented with the questions one at a time, select your answer, and then select Next, and when you're all done, select Finish. All right, we are going to give this a try together, so hopefully everybody has gotten connected to the polling software. And the question is, which emoji best represents your morning? Are you the angry, the happy, the sad, or the shocked emoji? So while you're entering your answers, you can see that the results will be calculated. And then when we see that you all have responded, then we'll go ahead and we will move on to the next slide. So let's see how everyone is feeling today. Oh, 66, 67, that's pretty good for, how many of us are happy this morning. Given that it's a bright, sunny day, I think we're doing pretty good. So thank you for participating. That's all you have to do for polling for the rest of the day, too. We look forward to everyone's participation today for our webcast participants. If you have a presentation-related question, at any point, go to the SurveyMonkey link that is on the CTEO website, and you can enter your question there, and we will present it later on at the end of the day during the open Q&A session. For our in-house participants, we ask that if you have a question, you address your question using the microphone that is in the center aisle of the room. We ask you to tell us who you are, where you're from, and speak into the microphone so that both our in-house and our viewing audience can hear your question. If you have a technical question today about polling, you're having difficulties, at any point during this event, you can send an email to tklagholtz@providerresources.com, and he will get back to you and help you out. If you have a technical question regarding the conference or webcast, you can send an email to CTEO techsupport@cms.hhs.gov. Okay, we are glad to have all of you here with us today. We have a packed house, which is really exciting. Our agenda today is packed with subject matter experts who are excited to share their knowledge and their expertise. So let's go ahead and get started. Kicking things off for us today, we have the Principal Deputy Administrator and Director of the Center for Medicare. Please help me welcome Demetrios Kouzoukas.
Good morning, everybody. How are you all doing? Good. We've got about 3,000 people, I think, on the webcast and a few hundred here in the room. I'm delighted to welcome each of you to the fall conference and excited to give you our greetings on behalf of the administrator and CMS. I know that a few of you are visibly angry in connection with the emoji, so I hope your day, for those of you who connected with that your day improves in particular. We also wanted to thank you all for your participation in the Medicare Advantage and Part D programs. I've been here for 7 months now at CMS, and it's really been a really exciting and educational experience. But it's been of particular interest and gratification to me to see how collaborative the stakeholders in the MA and Part D community are in terms of approaching CMS's shared mission with the various plans and others who deliver care on behalf of the Medicare program on a day-to-day basis. And it's been interesting to both engage on the operational issues and the challenges that you all face and that we face internally in making all this happen and all the pieces work together, but also as well on the bigger picture policy issues. So thank you as well for your participation and your continued collaboration with the agency on the success of the program. I wanted to state and sort of put out there at a high level for this conference and on an ongoing basis the shared goal that we have in ensuring that the best care that is made available to Medicare beneficiaries. And that is that's an individualized, I think, goal, one that relates to each individual and their circumstances. And so individuals obviously have an opportunity to choose how they access Medicare. We want to facilitate that. We want to give them as many choices as possible. We'll talk a little bit about that today. But I think that the meaning of this for each beneficiary is kind of brought home at times like this when we see what's happening with Hurricane Harvey and what we're preparing for with Hurricane Irma, the need for the healthcare delivery system to respond in even extraordinary times to deal with the challenges that the environment may bring us, but also on an everyday basis. And so it makes it all the more, I think, real and connected to each person. I've been hearing a lot of stories about people who are, rescued and the number of efforts that are made to save one person or to evacuate one small group of people. And sitting where I sit at CMS, where we sort of operate at a very high level with a lot of people impacted with every decision, it's been really impactful to see that in a very specific way, every one of those decisions, not just in hurricanes, but in every day, this drives it home, impacts real people in very individual ways. So it's in that spirit that we asked for ideas, transformative ideas about how we can improve the program earlier in the spring in our request for information. And you know that we asked in particular for ideas that would increase flexibility to enrollees, flexibility in the way that care is delivered to enrollees, so that they can choose the course that's best for them in terms of their individual health care and the way that they access the program. We got a lot of great ideas. I had an opportunity to review them at the spring conference with you, focused on transparency, flexibility, simplification, and innovation. And wanted to give you a little bit of an update, just in the sense that we're continuing to review those. We've spent a lot of time and energy sorting those that we think are actionable and appropriate for us to take action on, both at the staff and senior levels, at CMS, with the administrator and beyond. And we're continuing to make progress on taking those ideas and turning many of them into a reality. Some of them will require longer-term regulatory or statutory action, and so that's obviously a process that's involved and underway, but we are considering all those options. I also wanted to highlight for you a few of the things that we've done, and you'll hear about them over the course of the day, but also a bit for me that we've been busy enacting short of that, things that we've been able to do so far as well. In particular, I wanted to talk a little bit too about our audit process as a sort of an example of an area where we've been taking in some additional feedback as well. Our component responsible for program audits continues to seek feedback, and we've been engaged in some dialogue, I think, with folks in the industry and other stakeholders about how we can reduce burden but continue to ensure accountability. And we conducted an industry-wide listening session on July 18th on our independent validation audit process. Over 1,300 individuals participated, and we got many wonderful thoughts and suggestions. We're using this feedback to develop more standardized processes and provide additional clarification. We also completely redesigned our compliance program effectiveness audit protocol for 2017. As you know, we incorporated prior industry feedback into the redesign, and we look forward to continued feedback from this year's audits. So stay tuned for more information on that. Wanted to mention as well that we received a lot of feedback on the Part C and D program audit protocols during the Paperwork Reduction Act process, and we finalized those protocols for the 2017 audit year. Wanted to state today that we're not planning to make any changes for the 2018 program audit year, and so we'll continue to use those approved protocols. This is just a small sign of what we're trying to do to increase the transparency and predictability of how we approach things. And the underlying thought and philosophy is that the more we can do that, the more you can plan for how you deliver care and make care accessible to beneficiaries. Speaking of beneficiaries, we're nearing the beginning of enrollment for 2018, and it's really exciting to be here for my first CMS open enrollment period in this role. Really excited about the opportunity for beneficiaries to engage in an annual process to evaluate their coverage. A lot of the changes that we're contemplating and that we've already made are premised on the idea that individuals should have the opportunity to choose the way that they access the Medicare program and have as many options as they can to pick the best course for them. So we've taken steps to ensure that our marketing guidance enables access to meaningful information that beneficiaries can review, and wanted to highlight a few of the things that we made that we did in this year's guidance, particularly changes from the proposed to the final in response to public comment. And these will be familiar to those of you who work in this space, but you're no longer required to upload every marketing and sales event into HPMS. That may be some relief to those who have that work to do, also of some relief to those on this end who process that as well. And so we've been able to focus our efforts on other activities and priorities, but still maintain the same level of information and potential access should we need it. You can now send one document, such as the annual notice of change and evidence of coverage, to multiple enrollees residing in the same household when they're enrolled in the same plan. We expect this will save you duplicate mailing costs and reduce the amount of paper that lands in member mailboxes. Recognizing advances in digital communication, we're allowing you to send more member materials electronically. Formularies along with provider and pharmacy directories can be provided electronically. We're making it easier for you to communicate the value of Medicare Advantage by allowing you to send marketing emails to beneficiaries. We've made it clear that plans are only responsible for the content of third-party marketing websites that include benefits information when the plan has a contractual relationship with that third party. We've also provided some clarity about the fact that plans are allowed to pay field marketing organizations on a per enrollment basis. We've also recognized that in light of current technology, it's not necessary for us to regulate the font size of websites. These are perhaps at some level very operational, but I think that they're indicative of the way that we're approaching the entire range of ideas that we've gotten in from the RFI, and there's continued effort and work on that regard. I wanted to make sure you knew that, and I had a few examples. Separate from the marketing guidance, we're also reviewing the way we communicate with beneficiaries. So we're always, and this is something that is sort of a continuous improvement project, I think, for us. But we have taken a public comment on the Medicare and You handbook, and for those of you who read it with eager excitement every year, there'll be a few changes, I expect, in some of the ways that we talk about the options that Medicare beneficiaries have, and that's based on the public comment that we've received, which was quite helpful. And we're also looking forward to making similar changes in our other communications and continuing to get feedback from you about the way that we can communicate best with the Medicare population about the choices they have to access the Medicare program. We also wanted to make sure that you knew that in order to ensure that Medicare beneficiaries have meaningful information when making plan choices, CMS will be enhancing the benefit package data display on Medicare Plan Finder for 2018. These enhancements include adding more benefit categories, including preventive care, in-network versus out-of-network cost share information, authorization and referral information, optional supplemental benefits with monthly premium and deductible, and an expanded display for drug costs and coverage. These changes will go live on October 1. So it's been exciting to see both the policy and the operational level, some of the work we're doing come to fruition. For those of you who worked on giving us comments either in the RFI process or otherwise, we're grateful for the amount of thought and care that went into it, and we continue to look at how we can operationalize these things in order to make sure that people have access to the best information, that they can make choices, that competition will drive more flexibility, more options, more affordability, and better care. Our work to transform the Medicare Advantage and Part D programs has really only just begun. I look forward to continuing to engage with you on ideas that can modernize these programs. I hope you have a great conference and a great day. And thank you all for your time and your continued participation and service to Medicare beneficiaries.
Okay, thank you, Mr. Kouzoukas, for sharing with us this morning the update and the overview. Our first speakers today will provide information on the past performance analysis, one of the most comprehensive tools that CMS has at its disposal when making application decisions for Part C and D plan sponsors. The methodology, functionality, and new developments critical for plan sponsors will be discussed by Michael Neuman and Kerry Casey.
All right, well, my name is Michael Neuman, and along with my colleague Kerry Casey, we're going to be presenting on the past performance analysis, and welcome and thank you for coming today. A little bit about background about the past performance analysis. Many of you in this room know a lot about it already, and it's something that's been on the books since we've been using since even before 2010, but the regulatory authority was kind of vague, so we came up with a methodology to kind of sorry, one second. Yeah, we came up with a methodology to kind of codify and let sponsors know kind of how it operates. So basically, the idea of past performance is we're going to use organizations' past performance in Medicare as not a predictor, but really just a snapshot in time of their performance when making contracting decisions. And the idea behind that is that a plan should be able to take care of their current book of business before they can go and ahead with taking on new business or service area expansions. We want to ensure, for the beneficiary's sake, for the program's sake, that they're able to take care of that. So as you see on the screen, there's a regulatory authority. It's a longstanding authority to deny applications based on past performance. And the idea is that if there's a past performance outlier, and what an outlier essentially is really in this case we're dealing with extreme outliers, not just regular outliers. And the numbers over the years have really shown, to give you an idea, in this past year, CMS only denied 3 service area expansions out of 171. And that was one sponsor holding all 3 of those. So it's really not a lot, and the point isn't to be an impediment really to plans. It's to make sure that beneficiaries and the program are running and functioning well. So the idea is also is that even if an applicant otherwise meets all application requirements, they can still be denied on past performance grounds. And as many of you in this room know, it's a 14-month look back. So it's January 1 of the previous year, leading up to almost the application deadline through February 28th or 29th, depending on the year. So those 14-month period, and any action that's happening during that 14-month period is looked at across 11 categories. And Kerry, a little later in the presentation, is going to talk about exactly what is in those categories. All right, so the past performance review it's rigorous and systematic, it's fair and unbiased, it's quantitative, and it's comprehensive and multidimensional. And what I mean by that is we really take into account a variety of factors. And the idea is that we don't think a plan should be an outlier because they only had a couple compliance notices, or they had an issue in one category, or received one civil money penalty. We think that it should be comprehensive across multiple categories. So if you're going to be an outlier, the way it's weighted is that you're going to typically, and I say typically other than sanctions and some other extreme cases of termination, really the points, you're going to need to hit points in multiple categories to be an outlier. We don't want it to be a single category driven analysis. All right, so point values are assigned for each dimension. So point values vary depending on the nature of the problem and risk to the program and beneficiaries. So as you'll see, and Kerry will go through some of those point values in a little while, it's weighted to kind of, the seriousness of it is taken into account. So obviously a sanction is taken more seriously than a notice of noncompliance. And that's on purpose. We don't, again, this is supposed to be driven to look at extreme outliers. It's not supposed to just be for the idea that, a plan slips up. Ideally, all plans would be perfect throughout the year, but at the same time, CMS understands that that's not always possible. And, there is a little leeway that is given, and really what we're dealing with is multiple points across multiple categories. So, as I said before, the analysis identifies overall performance outliers. It really homes in on sponsors with problems in multiple categories and not just one. Overall negative scores are calculated at the contracting entity level. I'll pause for a minute just to discuss this a little bit. And the idea is that this is what we know as the contracting level is the actual plan contract, but we then roll that up to the legal entity level. So any contracts within one legal entity, they would get those points. The legal entity is assessed the points. And the idea is that legal entity is the contracting basis with CMS, and therefore any contracts that they actually have are subject to those points under that legal entity. I'll also point out we have something that's called a sibling policy, and the idea between that is that we actually will roll up to the parent company only in the instance where it's a new line of business, so a new legal entity that's coming in. If there's no business, we can impute some of that performance to the new one. But other than that, it's conducted at the legal entity level. Okay, so our first polling question, if everyone could fill out what they need. How many times per year is the past performance analysis conducted? I'll give everyone a few minutes. I'll give everyone another about 10 seconds. It's still moving around. All right, so the correct answer is not B, unfortunately. Well, it's actually C. So it's twice, once in the spring to make contract determinations and once in the fall for informational purposes with an eye towards the spring. So past performance, and I didn't lead with this on purpose because I wanted to just kind of gauge everyone's understanding of the topic, but it's conducted twice. So the spring past performance is conducted for the purposes of application decisions. But we do run one in the fall, and we're actually about to do that very shortly. And the idea behind that is it's sort of a predictor for the spring. Now, I know everyone's thinking it's a rolling past performance period. So that looks back 14 months from the fall date. So obviously not all of that compliance history is going to be included come the spring. Some of that's going to fall out. And, we work with plans all the time to kind of predict sort of, or, try to answer questions to the best of our abilities. We can't obviously say with absolute certainty, but, are some points going to fall out? Are other points going to stay on? But essentially, the fall analysis is merely a predictor for the spring. I say merely because there's one instance in where MMPs use it to make determinations for passive enrollment, but that has kind of wound down a little bit, so that's the only thing. But for Part C and Part D plans, essentially, the fall analysis is a predictor for the spring. The spring analysis is made for application determinations. Okay, so what to expect? Applicants with high past performance scores. So once we run our analysis, get all of our data, we post those scores in HPMS prior to the issuance of notices of intent to deny. Each plan is able to sign into HPMS, Health Plan Management System of record, and see whether or not, what their score is, if they're an outlier. Many plans will reach out to us, and also they will have questions, follow up, and we encourage that. So please, by all means, reach out to Kerry or myself, and if you have any questions. And, for the outliers, we give them the opportunity to withdraw applications if they are indeed an outlier. However, that's their decision, whether to invest in going further with the process. They can appeal the decision with the CMS hearing office. That's the first level of appeal. If they're successful there, then they would continue with the application. CMS has been extremely successful with the past performance analysis in the hearing officer, at the hearing officer level. And over the years, our methodology and our process has been upheld many times. So truly for outliers, run-of-the-mill outliers, CMS has been successful in denying those applications. However, if a plan were to have a result that they didn't agree with at the hearing office, they could appeal to the administrator if they wish, and that's another level of appeal. And then if they wanted past that, if they didn't get what they wanted, they could take us to federal court. I don't believe we've had anyone do that for the past performance analysis, but we have had some plans go to the administrator level. All right, so this is a little bit about what I discussed before about how many plans have been denied. And as you can see, it's really not too many. Starting back in 2016, this is the last 3 years, 26 organizations identified as performance outliers of 441 legal entities. And out of those, 0 out of 188 applications were denied for past performance of legal entities that submitted applications. Just one piece of, to shed some light on this, that doesn't mean that people weren't actually, you can see there were 26 organizations, that means either they weren't applying for new service area expansions or new lines of business, or alternatively, once they realized they were an outlier, they decided to pull their application. In 2017, there was 31 organizations identified as performance outliers out of 428 legal entities. And 3 out of 118 service area expansion applications were denied for past performance. So again, a very, very small number. We're dealing with extreme outliers here. We're not dealing with, numerous plans and numerous legal entities. And then in 2018, even less, 23 organizations identified as performance outliers out of 425 legal entities, and 3 out of 171 service area expansion applications were denied for past performance. So really, again, we're dealing with a small amount. Over the last several years, CMS application denials were based on past performance have been consistently upheld in response to requests for administrative hearing. And really, we've taken the hearing officer's, whatever his advice was to light. To give you a couple examples of that, we didn't used to even publish the methodology. We started doing that, obviously, for sponsors so we could be more transparent. And we have worked hard to make sure sponsors have that in advance so that they can have an idea of what's going on and what changes are made. Another example of that is we now solicit comment every year on the past performance analysis. We typically will be sending it out very shortly for comment, hopefully in the next couple of weeks to a month. And in the past, we've done about 2 weeks. This year, we're going to give a full 30 days for plans and Benny advocates and the industry to comment. We will then take those comments back, consider them, and then before publishing our final methodology later in the fall. The past performance review really is an evolving document, and it's really like a living and breathing organism. And just because something is one way 1 year, we take a lot of plan feedback, we take a lot of industry feedback, we take a lot of beneficiary advocate feedback. So there are 11 performance dimensions for the 2018 application cycle. And those categories and point values were updated since 2017. And the methodology will really continue to be updated and open to comment and publish, like I spoke about, to reflect the most current and comprehensive available information. Some examples of this over the years would be in the category which Kerry will describe a little bit more, but it used to be that in civil money penalties, plans would get either 1 or 2 points depending on how much money they were assessed for that civil money penalty. It used to be anything below $50,000 received 1 negative performance point, anything above received 2. And we found over time that the way that MOAG, Medicare Oversight and Enforcement Group, was conducting the actual assessment of the CMPs, it didn't make sense to do it on a per dollar basis anymore, so we dialed it back. And now all plans, regardless of size of the actual monetary amount, they only receive 1 negative past performance point for receiving 1 CMP. If you receive 2, you would get 2 points, but it's no longer predicated on the basis of dollars. That's one example of what we have done. We've also tried very hard to eliminate perceived idea of double counting where it is in the methodology. For example, we send out corrective action plans for star ratings every year for plans that receive below 3 stars, so 2.5 and lower. Those are specifically excluded from the compliance notice category when we conduct the analysis. The idea behind that is plans in one of the categories receive 2 negative performance points for star ratings, for receiving low star ratings. And what we really don't want to happen is to count that cap in another category when we've already counted the 2 performance points. So that's, we're cognizant of double counting. We try our best to make sure that there is an overlap, and each category to the extent is unique. If something is not, we see things sometimes can be aggravators. For example, beneficiary impact in a corrective action plan, that's an aggravator. We see that as an additional piece. That's why they receive 1 negative performance point in addition to the corrective action points. But we don't see that as perceived double counting. We see that as a different piece. So that's why sometimes you'll see extra points assessed. And point values may shift along with categories to reflect proportionate weight basis on new information and analytic techniques. And this is kind of what I was talking about with the CMPs. We got rid of per dollar basis. We've done this in other areas such as performance audits. We moved towards more of a 4 core areas versus just all areas of what a performance audit takes into account, because we thought that was fairer to plans to focus on 4 core areas where they were failing their audits versus a variety of other circumstances that might be more minuscule in nature and didn't really bubble up to the fact that they should receive a negative performance point. All right, so our next polling question. How many categories are in the past performance analysis? A, 11, B, 13, C, 9. I'll wait a little bit for your answer. All right, so most people got it right, 87% or so. The answer is A, 11 categories. And while there are sort of subcategories sometimes of ways that you can get points, such as our exclusion category, et cetera, there are 11, I guess, core categories, and Kerry will talk more about those shortly. All right, this is important. Performance information is not a secret. We have become more transparent at CMS than we ever have with the past performance analysis. When we started out, we made calls to sponsors to alert them whether or not they were past performance outliers. There was nothing that was given that was concrete. There was no emails that were sent. It was conveyed to them, and that was it. Over the years, we have become more and more transparent, and organizations have the same information CMS has about their performance. Some of that information that we now make available to sponsors is within the health plan management system. We now have the ability for plans to be able, for about over a year now, to see and track their own compliance history. It's no longer, we don't require plans just to, file the emails that they get and the compliance notices that we send. It's in there. As soon as we send it, we do it within the system. It categorizes it. It has it there. It is available to be seen at any time from the moment we send it out. And that's a wonderful thing, I think, for plans. So there's no more guesswork when it's time for us to run past performance for the most part. And plans, I should say, many plans are excellent at predicting exactly what scores they get because they follow this and they track this. And their compliance officers are phenomenal at that. And I applaud everyone who works with us and reaches out to us to make sure that their scores are in line with what they expect. And if there's not, please, by all means, again, reach out to us. We're happy to help. There's nothing that feeds into the CMS analysis that's not already available to the MA organizations or Part D sponsors. Again, this is information that is available to sponsors at all times. We have become more and more transparent. We have in our letters and our compliance notices, if issues are Part C, Part D, or cross-cutting issues, which are important for the analysis, since we conduct a Part C and a Part D analysis, plans need to know if it affects Part C and or Part D. And that is upfront in the letter with information that it lets plans know that it's counted for past performance at the end of, in the fall and the spring. And so the results really should not be a surprise to sponsors. And if for some reason anyone in this room or on the phone today finds that to be a surprise, please reach out to us and we can help you, point you in the right direction where that information is indeed available. All right, so the application cycle past performance review methodology. The most current one that will be used for the fall, this upcoming fall, and was used in this past spring analysis, was published on February 10th, 2017. And it's labeled the 2018 Application Cycle Past Performance Review Methodology. It's in HPMS if anyone wants to take a look at it. However, we will be putting out shortly, in the next couple weeks to a month, as I stated before, our new methodology, which will be applicable for the spring analysis. And we will look forward to everyone's comments on that. And once it goes out, there'll be an HPMS blast to alert everyone that it's out for comment. All right, so I'm now going to turn it over to my colleague, Kerry Casey, to walk you through the categories.
Good morning, everyone, and thanks, Michael. So this part of the presentation goes into a lot of the very nitty-gritty details about the past performance dimensions. So I'd strongly recommend taking a look at the methodology as well. This is going to be a lot to remember just from hearing it once. So as Michael has said, there are 11 past performance dimensions: compliance letters, performance metrics, multiple ad hoc caps with beneficiary impact, fiscal soundness, program audits, 1/3 financial audits, exclusions, enforcement actions, terminations, non-renewals, and outstanding significant compliance issues not otherwise identified. Part C and Part D scores are calculated separately, as Michael said. Legal entities are assigned the points from their contracts, so the highest points for each of their contracts in those categories. And an outlier on the Part C side is a legal entity that receives 4 past performance points or more, and a legal entity on the Part D side that receives 5 or more past performance points is considered an outlier. And this is because there are several categories applicable to Part D that is not applicable to Part C. So the first category we're going to look at is compliance letters. And I just emphasize here that our goal is to identify organizations and sponsors receiving a high number of compliance notices, outliers, not just a few minor issues, but serious issues. And how we do this is we calculate a score, which is weighted according to the seriousness associated with the notice. A contract in the 90th percentile or above receives 2 points. A contract between the 80th and the 90th percentile receives 1 point. In Part C, we've instituted floors for the 80th and the 90th percentiles of 3 and 5, and this is to ensure that we really are identifying outliers. Now, compliance letters are divided into Part C issues and Part D issues. Part C includes notices related to health benefits or to health and drug benefits. The Part D analysis includes issues related to drug benefits or health and drug benefits. The type of issue is identified in the compliance letter in order to maintain the transparency. So these are the weights that we assign. Oh, I apologize. These are the weights that we assign to the different types of compliance letters. So notices of noncompliance, which are mildest type of letter and do not contain specific language regarding escalation due to continued noncompliance, are given a weight of 1. A warning letter, which is beginning to increase in seriousness, is given a weight of 3. And these letters explain consequences of continued noncompliance. Warning letters with business plans are given a weight of 4 points. These require written response from a plan explaining the corrective steps that are going to be taken. And ad hoc caps are the most serious type of compliance letter, and they are given a weight of 6. These indicate continuing or systemic problems. Now here's an example of how a score is calculated. A plan that received 1 notice of noncompliance would get 1 point. A plan with 2 warning letters would get 6 points, and a single ad hoc cap would be 6 points. Taken together, that would be a score of 13. Now, our thresholds for the 80th and 90th percentiles do adjust every analysis, but a score of 13 would typically be over the 90th percentile and receive 2 points. So here's my first polling question. What is CMS's definitive system of record for compliance notices? We have HPMS, emails, and marks. All right. And I think you all have the right picture. HPMS is our system of record. The compliance activity module tracks all of the compliance notices that we issue. Next slide. So the next category we take a look at is multiple ad hoc caps. Multiple ad hoc caps are rare. There was only 1 legal entity that was assigned points in this category in the spring 2017 analysis. And more than 1 cap is an indication of ongoing performance problems. Now our next polling question. How many past performance points does a contract get under this category if they have multiple ad hoc caps? 2 options, a contract gets 1 point total if they have multiple ad hoc caps, or a contract gets 1 point per ad hoc cap. All right, so we've got some diverse viewpoints on this one. So the correct answer is A, a contract gets 1 point total if they have multiple ad hoc caps. Next slide, please. Our next category is ad hoc caps with beneficiary impact. So ad hoc caps are deemed to have beneficiary impact if the problem that resulted in the cap was related to the delivery of service to members. Contracts receive 1 point per ad hoc cap with beneficiary impact. Now, an example of a cap without beneficiary impact is a cap issued for late reporting of financial information to CMS. That type of a cap doesn't reflect on the beneficiary's day-to-day experience of Medicare services, and so would not have beneficiary impact. On the other hand, a cap that does have beneficiary impact might be one related to errors found in the ANOC or EOC. That's a document for beneficiaries that they use to understand their benefits, and so would be deemed to have beneficiary impact. So how do you know if an ad hoc cap has beneficiary impact? So the compliance letter will specify beneficiary impact. HPMS will identify as having beneficiary impact, or both. All right, we've got the right answer this time for most people. C, both. And one thing that I'd ask of you, if the information in the letter doesn't match what's in HPMS, that's one of those times when you need to contact CMS so that we can make sure that we have the best record. Next slide. Now moving on to performance metrics. So these are based on star rating data, which is posted on Medicare.gov. Contracts with a summary score of 2.5 or below are identified as outliers. On the Part C calculation, we use the Part C summary rating, which includes the following domains: staying healthy, managing chronic conditions, member experience, complaints, and customer service. On the Part D side, we use the Part D summary score, which includes customer service, complaints, member experience, and drug pricing and safety information. Contracts that are outliers in this category receive 2 points. The next category is failure to maintain fiscally sound operations. CMS requires all MAOs and PDPs to at least submit annual audited financial statements. All PDPs and some MAOs are also required to submit quarterly financial statements. MAOs and PDPs are required to maintain a fiscally sound operation by at least maintaining a positive net worth. Organizations that don't meet this requirement receive 2 past performance points. And as Michael said, we've adapted our methodology over the years. Previously, there was an additional point in this category for organizations that had a net loss greater than 1/2 of the entity's net worth. Over the years, we've determined that the negative net worth is a better estimation of an organization's risk to the program, and so we revised our methodology there. There are 2 types of audits that we include in past performance. The first is the 1/3 financial audit. Organizations that have an adverse audit where financial data is materially misstated, or a disclaimed audit where the auditor could not form an opinion due to circumstances created by the audited MAO or PDP. Organizations with these audit findings receive 1 point in this category. These findings indicate a lack of internal controls or necessary resources to participate in the audit, and so raise concerns about risk to the program. Program audit is also a category in the analysis. We developed a modified audit score that includes 4 core program areas that tend to be consistent over time, and these areas are Part D formulary and benefit administration, Part D coverage determinations, appeals and grievances, Part C organizational determinations, appeals and grievances, and compliance program effectiveness. The scores in these 4 areas are added together and divided by the number of audited elements. Organization with scores over the 75th percentile get 1 point in this category. Now, there are 4 types of exclusions that we include in the past performance analysis. The first is exclusions from receiving LIS reassignees or monthly auto enrollees. This category is applicable to Part D only. CMS has the ability to auto-enroll beneficiaries who receive low-income subsidies into a Part D plan if they haven't selected their own plan. We're also able to reassign beneficiaries to a new plan if the premium on their current plan is increasing beyond the amount of the subsidy. In cases where CMS has to suspend an organization from participating in this, they can receive 2 past performance points. If the exclusion is ongoing at the time or at the end of the performance period, they receive 3 points in this category. The next exclusion is from the Medicare and U handbook. And this happens in instances such as when an organization fails to complete contracting requirements with CMS. They're eligible to receive 1 point in this category. And I note that in cases where the exclusion is due to a factor that's captured somewhere else, such as due to a sanction, in those cases, they're not given an extra point in the Medicare and U handbook for that exclusion to avoid any issues of double counting here. The next category is also Part D only, and it's exclusion from performing formulary updates. In some cases, Part D has to exclude organizations from participating in summer updates of the formulary. In those cases, an organization receives 1 point in this category. And finally, we have exclusion from the online enrollment center. Organizations that don't retrieve data from the online enrollment center are eligible to be excluded from participation, and those organizations receive 1 point in this category. And the next category is terminations and non-renewals. So there are various termination and non-renewal scenarios that CMS has concerns about. They include requests by an organization or sponsor to mutually terminate or non-renew a contract or portion of a contract service area after the non-renewal deadline or after marketing has begun. Contracts that terminate, non-renew, or reduce for the upcoming contract year very late, especially during an AEP, are problematic, and terminations initiated by CMS are the most severe. There are a range of points that can be applied in this category. Mutual terminations that occur after the non-renewal deadline, but prior to October 1 can receive 1 point. Any mid-year mutual termination and terminations where CMS has less than 90 days notice receive 4 points. Partial terminations imposed by CMS are eligible for 4 points, and complete terminations initiated by CMS have a value of 8 points. The next category are enforcement actions, and in these we have intermediate sanctions and civil money penalties. Both of these are rare and reflect significantly impaired performance. Organizations can appeal their results in these when they are issued sanctions or CMPs. Points are issued during the appeals process. However, if an organization wins an appeal overturning the enforcement, no points are assessed. Each CMP can receive 1 point. And as Michael said, this is another area where we have adapted. And so points are no longer assessed based on the value of a CMP. Sanctions points vary depending on the type of sanction. A non-immediate sanction receives 2 points. An immediate sanction can receive 3 points, and 4 extra points are assessed if the sanction is still in effect at the end of the performance period. Our final category is outstanding significant compliance concerns. This is very rarely used. For instance, no points were assigned in this category in the spring 2017 analysis. And this is used when CMS has identified noncompliance that supports a sanction, a CMP, or termination, but has not yet been imposed. CMS has already verified facts of severity and scope, but has not yet issued a letter due to internal processes, and again, used in very limited circumstances. Depending on the seriousness of the outstanding issue, between 1 and 5 points can be assessed. So I would just conclude by saying we have made adjustments to this methodology over time based on industry comments, and we'll continue to do so. We've received comments from the request for information that went out earlier this year and are working to incorporate that where possible into future methodology. And there is an opportunity to comment on our 20 methodology and upcoming. And again, transparency is our goal. We don't want this to be a surprise. We want organizations to understand where they fall within past performance and why. If you have any questions, you can contact Michael Neuman and myself at these email addresses.
Okay, we do have time for questions, so if there's anyone in our in-house audience that has a question for Michael or Kerry, please step to the center microphone, introduce yourself, tell us who you are and where you are from. Okay. Well, I do have a couple questions here, so in the meantime, if you do have a question, please step forward. But we'll go forward with the ones that I have. And the first question is, are PACE organizations included in the analysis?
So PACE organizations are not currently included in the analysis. They're excluded. However, I should mention, PACE organizations do receive compliance notices and a variety of other compliance-related issues. We have considered it over the years, but as of now, they are excluded from the analysis.
Okay, and the second question that I have, why does Part D have a higher negative past performance threshold than C?
As I mentioned, because Part D has a few categories that are specific to it, such as LIS exclusions and formulary exclusions, we determined that a higher threshold for Part D was appropriate.
Okay, one last opportunity to ask any questions. Do you have a question? Okay, if you could step to the microphone in the center, please, and tell us your name and where you're from.
Hi, good morning. I'm Deidre Gray with Mantech International. I just had a very quick question regarding the compliance letters. Will you always receive a compliance letter prior to an ad hoc cap or not necessarily?
Sorry, could you repeat? I couldn't really hear so well.
So in the 11 performance dimensions, you start out with the compliance letters. Is that always the first step, or can you go directly to an ad hoc cap?
No, we can go directly to an ad hoc cap depending on severity of the issue. But like I said, usually, typically, in some instances, I would say there's two ways to look at it. If something is so severe and there's a severe beneficiary impact, we sometimes do go straight to an ad hoc cap. However, there are many times in some of the data-driven analyses that we run where it's a building process where you'll receive a notice of noncompliance and then a warning letter with a business plan, and then all the way up to an ad hoc cap with some resetting principles depending on if there's time in between in the quarters. And we kind of have standard operating procedures for depending on what type of category or what type of compliance that falls into. But I would say either one of those is available to us. Typically, we strive for lower level compliance first before running straight to the heavy hammer, so to speak.
Okay. Well, if there are no more questions at this time, then I would like to thank Michael and Kerry for providing the information on past performance analysis. Thank you. It is time for our first evaluation of session 1, and please take out your phones if you're going to text your responses or go to the Poll EV link if using your smartphone, tablet, or computer. Please respond A to the question I would like to evaluate this session, and then click on the link that is presented to you. That will take you to the survey. Please complete the 4 questions and then hit finish when you are done. That will submit your answers. Our next speakers will provide an update on encounter data activities, including recent developments and progress. From the Division of Encounter Data Risk Adjustment Options, Shruti Rajan, and from the Division of Payment Policy, Monica Reed-Asante.
Good morning, and thank you for joining us today. In this session, we'll be presenting an update on encounter data submissions. As you all know, CMS has been, you can't hear me? Let's see. Okay, can you hear me? Okay, great. So as you all know, CMS has been collecting encounter data for roughly 5 years, since 2012. So we wanted to take stock of how far we've come and present information on where we're going. Today's presentation has 3 parts. We'll begin by discussing the current state of submissions. The second part of our presentation will be about CMS's Encounter Data Integrity Plan and our efforts related to ensuring the completeness and accuracy of encounter data. And we'll finish with a few thoughts on where we're going. So before we get started, we wanted to take a moment to gain a better understanding of our audience. So we have a couple of polling questions here. The first question will help us understand your experience level with MA encounter data. So how long have you worked with MA encounter data? A, less than 1 year, B, 1 to 2 years, C, 2 to 5 years, or D, 5 or more years. Okay.
Interesting.
It is. Great. So that's very interesting. It'll help us kind of think about training sessions and whatnot in the future. So thank you. Okay, and we have one more polling question. We'd like to understand the roles that different people play in submitting encounter data to CMS. So on this slide, we have a list of different roles involved in creating and submitting encounter data. Encounter data processing, policy and compliance, error resolution. So let's see, okay, policy and compliance.
Interesting.
So the other, I guess. Okay. All right, thank you. Oh, we're still collecting. Okay, so it looks like most people, the majority are policy and compliance. Okay, and then other. Okay. Oops, did I go past a slide? Did I miss one? Okay. So the last time we presented on encounter data was during the spring 2016 conference, and we talked about how encounter data is big data, and there are various features of big data, but the most noticeable aspect is volume. So we're going to spend the next few minutes updating you on submission volume. Where do we stand? Okay. So on this slide, we can see that the volume of encounter data is growing. We've included the enrollment trend line here. That's the gray line. And that shows that part of the growth in encounter data volume is related to growth in MA enrollment. But as the overall encounter data environment has matured, we're also seeing a growth in submissions per beneficiary. So on the right there, you can see our forecast for 2015 is 775 million records. And then in addition to the annual forecast that we just showed, we have calculated a monthly projection and an estimate for the 5 years from 2013 through 2017. So for this month, we expect to process about 65 million records. That's September 2017. And then for the 5-year period from 2013 to 2017, we expect to process just over 3 billion records. That's big data.
Yeah.
Okay, so the next 7 slides or so present data on edit rates. We kind of wanted to show how overall kind of the accuracy of the data is stabilizing over time too. And as many of you may know, we have edits in the front end that are captured on the 277 CA acknowledgement reports, as well as edits in the back end system that would be contained in your MAO 002 reports. So here on this slide, we're looking at front end edits, and this table is showing the 5 most frequently occurring edits by submission period. So you can see that edit 255 is the most frequently occurring edit across all submission periods. And I'd like to point out the spike in 2016 submissions for that edit. You can see that it went from 0.55% to 1.53%. And when we first pulled this data together several months ago, we noticed that spike and wanted to look into it some more. So what we did was we first tried to identify whether what was sort of the reason for that. And so as it turned out, we identified 2 submitters who were experiencing difficulty with that edit, and we think it was because of some staff turnover and some newer staff who probably weren't as familiar with how that edit works. So we provided technical assistance to those submitters and helped them resubmit the data correctly. So as you can see, the edit rate is going back down in the first quarter of 2017. Okay, this slide also adds information from the second quarter of 2017 and is just displaying the same information I just showed you on the previous slide, but graphically. So you can see the red bars are 2016, and under Edit 255, you can see that spike in the red bar, and then the green and yellow bars are showing how that actually comes back down in recent submissions. So, and it's just a bit lower in 2017 quarter 2 than it was in the first quarter. This slide is just providing you the actual edit description for the graphic. On the previous slide, I couldn't fit it all on, so just for reference. Okay, so let's move on to back-end edits. So this is what would be reflected on an MAO 002 report. We've been conducting analysis on the most frequently occurring edits in the back end and presenting findings from our analyses during our monthly user group calls. We plan to continue this analysis and share the results as we get them in our user group calls. So overall, the back-end edit rate is low. It's about 2% if you took out the duplicate edits, and it's been decreasing over time. So we can look at the back-end edits in the by the modules, the professional, the institutional, and the DME. For professional and counter data records, the most frequently occurring edit. The slide didn't move. What's going on? Oh, wait, hold on. It did move. This is the right. Okay. Okay, so for are we on? No. It's on DME. Okay, there we go. Okay, so for professional, this is showing you professional module edits. And as you can see, in the first quarter of 2017, the most frequently occurring edit is 98320. We made a modification to this edit to include the linking ICN as part of the duplicate check. And that modification will go into effect on September 29th. So we hope to see a decrease in this edit rate for 98320 in coming months. During the July user group call, we presented our analysis on edits 02240, which is the second most frequent edit here, 02256 and 02125. Those are all enrollment and beneficiary demographic types of edits. In the sample data we reviewed, the member information submitted on the records differed significantly from the member data in the EDPS reference tables. And so we encourage you to verify member information provided in the monthly membership reports. And if you continue to have issues with these edits, please contact us at the encounterdata@cms.hhs.gov mailbox. Including the edit codes in the subject line will help us to easily identify those inquiries and help look into them. Okay, so this next slide is about the institutional module, back-end edits. The most frequently occurring edit here is 98300, the exact inpatient duplicate encounter. Through various communications with plans, we've heard of concerns about this edit. The reasons for these concerns are varied, and many times they include plans attempting to resubmit an encounter, but with a change in diagnoses or some of the other data fields. And so our analysis indicates that the data elements on these duplicate records might differ between the duplicate record and the original submission. And so we're considering options related to this edit. We've also conducted analysis on the 00800 and the 00760 edits, and we'll be presenting that information in upcoming user group calls. Okay, and then for DME, the most frequently occurring edits are some of the same as we saw before, the 02240, 00760, 98320. Oops. Okay. And this is a graphic depiction of the edit rates. This actually, though, is not showing the edit rates by module. It's just the overall edit rate across professional, institutional, and DME combined. These rates reflect the fact that the volume of professional records is so much higher than institutional or DME, because you can see that 98320, which was the most frequent edit for professional, is kind of the highest frequency here. So the professional is really going to affect what the overall edit rate is. So the main takeaways are that the volume of data is growing as we would expect, and that the edit rates overall are continuing to decrease slightly, and they're stabilizing over time. So I think that's all good news. Oops. Okay. So in the next part of our presentation, we'll turn to discussing CMS's efforts that we are taking to ensure the completeness and accuracy of encounter data. We've developed an MA encounter data integrity plan and began implementing it in 2015. And the two primary goals of the plan are, one, to validate the completeness and accuracy of encounter data, and two, to communicate with MAOs on the best ways to improve encounter data submissions. So the encounter data integrity plan is made up of 4 primary activities. All 4 activities are interrelated. They're presented here in a list, but work in all of these areas is ongoing concurrently. The 4 activities are 1, analysis, 2, communication with MAOs, 3, monitoring, and 4, compliance. And at this point, I'll hand the mic over to my colleague, Monica, who will present on our efforts in each of these areas.
Thank you very much. As Shruti mentioned, there are 4 core activities in the integrity plan, with analysis really being the crux, being the one that's supporting all of the other pieces. And Shruti mentioned a key area in which we're doing analyses, which is the edits and system analyses. And that includes looking to see if edits are centralized, if they're affecting specific submitters, and then also analyzing the edits to make sure that they are functioning as intended. And that's really a piece of the analytical work that we're doing to really try to understand better encounter data submissions. And so in addition to the edits and the system analytical work that we're doing, a large body of our work is actually analyzing encounter data volume as well as the completeness of encounter data. And completeness within the scope of the analyses that we're doing can be perceived as completeness at the record level, so data element level validity, and also the completeness of record volume. We do analyses that are focused a lot on doing record level counts and also looking at submission patterns. And our data level element review is really to analyze the accuracy of the information that's submitted in specific fields. And today we're going to share some of the record level analyses that we've done and some of our findings. There we go. Okay, so this slide gives an overview of the analytical work that we've done. It really kind of shows the evolution of our analyses from our starting point and then for going into delving more into specific areas. So we've been doing encounter data volume analysis since 2014. Most of our analysis have been at the entire encounter data record level. Looking at volume there. And we've also delved into looking by service type, so professional, inpatient, outpatient, and DME, and then also looking at service years and looking at volume over the course of several service years. One of the things that we have tried to do, and you'll see this in the upcoming slides, is control for enrollment in our analyses. So you'll see that many of the analyses are based on encounter data records per 1,000 enrollees. And the starting point for our analyses was really comparing encounter data records to fee-for-service, specifically comparing encounter data record volume per 1,000 enrollees to fee-for-service claims per 1,000 enrollees. And we recognize in doing that fee-for-service may not always be the most appropriate benchmark. We are looking at other options for benchmarks. For example, encounter data is maturing, and so it may be appropriate to look at the encounter data record volume per 1,000 enrollees for a specific organization over multiple service years versus comparing that organization to fee-for-service, actually comparing that organization to itself over the course of years. So that is something that we're looking into also. The comparisons that we're going to show you today are at the national and regional level. And as I said, some of this has sparked more in-depth analyses, and one area that we have done more in-depth analyses in is the inpatient encounter data records. We started off with our base analysis using fee-for-service as a benchmark. We also did some analytical work adjusting the fee-for-service benchmark based on information that we found in an NBER study. So we'll look at that also. In addition, we've done some comparisons of RAPs to encounter data level matching. And then we've also used external data as a benchmark using what we refer to as no-pay inpatient claims. So we'll look at that also. We do want to point out before we look at this that, again, this is at the national and regional level. If you look at this data at the submitter level, it will not necessarily follow this pattern. There may be variation, so we do want to point that out. Okay, so we're going to start off with professional. And again, this is our base analysis comparing MA encounter data records per 1,000 enrollees to fee-for-service per 1,000 enrollees, with MA being that purplish bar and fee-for-service being the bluish-greenish bar. And you can see that over the course of the 4 service years that we have here, 2013 to 2016, MA has been pretty consistently lower. The slides that we have here give the information in counts, but if you look at this as a percent of fee-for-service, MA is about 86% of fee-for-service in 2013, and that goes to a high of 94% in 2015. For 2016, it's about 91% of fee-for-service, and that's to be expected because 16 is not complete yet. But we think that based on this analysis and from the perspective of completeness, that professional is actually faring pretty well. Okay, so this is the same analysis, except it's for outpatient. So again, looking at the MA encounter data records per 1,000 enrollees in comparison to fee-for-service claims per 1,000 enrollees over the course of those 4 service years. And you can see that the counts here are pretty significantly lower than professional, which is to be expected. Again, this is at the count level, and if you look at these at percent of fee-for-service, the range is about 62 to 67% of outpatient claims. And again, 2016 looks a little bit lower than 2015 because of the completeness issue. Okay. So we'll get into the inpatient analysis. And again, we started with that base analysis for inpatient, comparing the encounter data records per 1,000 enrollees to the fee-for-service claims per 1,000 enrollees for inpatient. And you can see here that these counts overall are lower, much lower than both professional and outpatient. And MA is consistently lower than fee-for-service over the course of the service years. And then in terms of percent of fee-for-service, it ranges from a low percent of 61% in 2013 to a high of 72.5% in 2015. And that really sparked for us a want to understand why we were seeing this difference. We were thinking it could be submission issues, or it could be lower utilization, or maybe a combination of both of those things. So we did some additional analyses, and the first place we started was the team went out and looked for information comparing utilization of inpatient utilization for fee-for-service and MA. And they found a study by MBER that was released in January of 2017. And that study looked at MA and fee-for-service claims for 2010. And that study did find that for MA, the MA inpatient days were roughly 16% lower than fee-for-service. And so we used that as a basis to adjust the fee-for-service benchmark that we were looking at. So we took the information that I presented on the previous slide and adjusted the fee-for-service benchmark, lowering it based on that 16% difference. And so when we did that, you can see that it decreases the difference a little bit. And so when we look at it from a percent perspective, MA as a percent of fee-for-service increases from 61% to 73% in 2013 with that adjustment. And then it goes from 72.5% to about 86% of fee-for-service with that adjustment. And so with doing this adjustment, encounter data looks much more comparable to fee-for-service. Okay, this is the last analysis, and this is the one that I was referring to where we looked at encounter data and RAPS matches, and we used the external data source of no pay inpatient claims, as we refer it. And these are claims that hospitals submit, and most hospitals are required to submit as part of the disproportionate share hospital payment program. And so most hospitals are required to submit claims for all of their beneficiaries in order to support this program. And so theoretically, no pay claims would have a counter submission in RAPS, inpatient RAPS, and also encounter data. And so that's what we did. We took the no pay inpatient claims and compared them to RAPS and encounter data records, and we matched them on 4 fields. We matched them on beneficiary ID, contract ID, claims from date, and claim through date. And so this slide illustrates the results of us matching those no pay claims to RAPS and encounter data. And so we're going to start with the bars on the farthest right side there. So these percentages are the percentages of no pay claims where we found a match in RAPS and encounter data based on those 4 fields. And so the blue bar is 2013, the red bar is 2014, and the green bar is 2015. And so we did this over a span of 3 service years. And you can see that the match rate has increased over time with about 77% being in 2015, where the no pay claim matched based on those 4 variables, both encounter data and RAPS records. And then the second group of bars from the right are instances where, in their percentages, of no pay claims where we did find a match in RAPS, but we did not find a match based on those 4 fields in encounter data. And so you can see there that I think the takeaway here is that that number has been decreasing over time. It's at about 12% for 2015. And then the third set of bars, again moving from right to left, those are the percentages of no pay claims where we did not find a matching record in RAPS or encounter data. And so you can see there that's pretty leveled off, and we're about 5%. And then the last group of bars, which are to the most left, are percentages where for the no pay claims we found a match in encounter data, but we did not find a match in RAPS. And so I think that the general takeaway from this is for those, that third grouping, or actually the second grouping from the right of bars, that had the percentage of matches that we found in RAPs but did not find in encounter data, where that 12% is, that is, an indicator to us that there is some difference in submission patterns for RAPs and encounter data for inpatient records. Okay. So those were our service type analyses. We wanted to share a few other analyses that we've done with you, one being beneficiary utilization, and then the other being geographical maps that we'll show. And so for beneficiary utilization, we did the distribution of beneficiaries by utilization for the 2015 service year. And essentially what we did is create a count of fee-for-service claims for every beneficiary, and we did a count of encounter data records for every beneficiary, and then we grouped them into categories, into groups of counts, and we compared them. And so MA is in purple, and fee-for-service is in that bluish color. And so a couple of things to note here. For the zero claims bars, which are all the way to the left, there's about a 4 percentage point difference between MA and fee-for-service, with 5.2% of MA enrollees having zero services, and that's compared to about 9.1% of fee-for-service beneficiaries having zero services. And then as you move towards increasing number of services and you get to that category of 16 to 30 per year, we see a higher percentage of MA over fee-for-service. Okay. And the next two slides are geographic distributions of encounter data records based on specific ICD-9 codes. And this one is a geographical distribution of records that have the specific code 42731, AFib, not otherwise specified. We do want to point out that this is not, we're not drawing any conclusions from these slides and from this information about prevalence, but it does reflect differences, geographic differences in coding of this specific diagnosis. And also the geographic categories that we used for this are the MA regions. And so you can see here that the blue regions have the highest percent of encounter data records with AFib submitted as the principal diagnosis, so submitted in the principal diagnosis field. And regions 1, 6, and 19 are the ones that have the highest percentage of encounter data records submitted with this diagnosis as the principal diagnosis. And then the lowest incidence of encounter data records with this diagnosis as the principal diagnosis are in the orange regions, and there's about 7 of them that had the lowest. Okay, so we're looking at a different diagnosis code now. This slide is analogous to the previous slide, except here we're looking at diagnosis code 40190, which is for hypertension not otherwise specified. And you can see here that there is a higher percentage of encounter data records with the principal diagnosis code of 40190 than there were with the diagnosis code of atrial fibrillation that we just looked at. But the difference in coding in MA region is noticeably different for the code. And as we noted before, we're not trying to make any conclusions here about prevalence. This is just a way to demonstrate the tools that we're using to look at geographic distributions. One thing to note, though, is that for some of the regions, for regions 8, 10, 16, 22, and 24, they were in the lowest category for the atrial fibrillation map that we looked at. And they're in the purple category here, which is the second to lowest category for hypertension. Okay, so that concludes the analyses that we wanted to share with you today. We're now going to go back to talking about the remaining activities that are part of the integrity plan, communication being one of them. And just to remind you, we talked on slide 16 about the 4 major activities Communications was the second one on that list. And we'll talk about some of the vehicles that we use for communicating with MAOs in a minute. But this is an integral part of the plan for us. It's a way for us to understand the submission process from the perspective of the submitter, and it's also a way for us to work to ensure that we are doing what we can to help with timely submissions and with processing of encounter data, and that we can provide feedback and receive feedback. So there's a number of vehicles that we'll cover, and there's a number of ways that we're communicating. One is through site visits. We've done a number of site visits, and I think that our goal is to have 20 completed by early 2019. And these site visits are really an opportunity for us to understand the beginning to end processing from the perspective of the organizations. And so, from the beginning of data being provided to the organization from the provider and their processing of it and the packaging up and sending off to CMS and submitting to us. And so it's really a way for us to understand that whole flow of data. In addition, we've been doing one-on-one calls, and these calls have really been fueled by the analytical work that Shruti and I both discussed. We've been using that work as a basis to generate discussion on these one-on-one calls, and it's, our initial focus was to explore and to try to understand, based on what we were seeing, what was driving those things, and the one-on-one calls have been a great source of information for that. We also have monthly user group calls, and for these, when we did the polling, it was clear that there's a variety in the level of experience and also the positions ranging from policy, pure policy, to operations. And so we try in the user group calls to have a full breadth of information to cover that. And so we use them for program updates, to provide clarifications, to encounter data submissions, for technical assistance, and then also for training. In addition, we have our mailboxes. We have the risk adjustment mailbox and the encounter data mailbox, and we receive an extensive amount of inquiries into those mailboxes, many of which require a lot of research and follow-up. So that's another extension of communication that we have. And also we have our research into edits, and we're continuously analyzing the most frequently firing edits, again, to see if they're centralized for a certain submitter and also to ensure that they're functioning as intended. And then there's best practices. And we've really honed in on the experiences that we've had from the site visits, and we use those to develop a list of best practices that we shared with stakeholders through an HPMS memo that was released this past June. Okay. So the next activity is monitoring, and that was the third activity that Shruti mentioned in the integrity plan. And for monitoring, our main goal is really to provide information that will allow stakeholders to do self-evaluation. And so, for instance, on the one-on-one calls, when we shared the information that we were seeing, the data that we were seeing for the inpatient encounter data record volumes, in some cases that sparked the organizations to go back and do an evaluation themselves. And that's really what the goal of monitoring is, to share that information so that organizations can go back and do self-evaluation. And monitoring is also linked to compliance. The information that's gathered through these monitoring activities helps inform compliance activity and planning for compliance in the future. So just as we did with communication, we thought we would list some areas in which we're doing monitoring. I'm sure you all are very familiar with the report cards, the encounter data report cards. We've been releasing them since 2015. And we're working on releasing them in the Excel format to help with the data being more easily ingestible. And we're also working on including more information on them. And in addition, the next two bullets cover the one-on-one calls. We've been doing monitoring through the analyses that we've been doing up front, such as the inpatient analyses, the edit analyses, and so that's supporting monitoring from the perspective of analyses that we're doing before we join the one-on-one calls that are supporting the basis of the one-on-one calls. And then we're also gathering information from the one-on-one calls that we're using to spark some additional analytical work. And then we have all of the analyses that we presented earlier, which are the broader trends looking at service type and service year analyses at the national and regional levels. And we're also working on new analyses to help us better assess the completeness and the accuracy of the data. Okay, compliance. So the fourth and final activity is compliance. And our main interest in compliance is really as an activity for organizations where performance doesn't meet the expectations for performance, and working with those organizations. And in the 2018 call letter, we released our general approach to compliance and solicited feedback, and we got a fair amount of feedback based on that. So the next two slides that we're closing with provide our next steps. We've talked about where we are with things, and I think our next steps are really a continuation of what we're doing and enhancing what we're doing. So for analyses, we're going to continue to look at data element validity, ensuring the accuracy of the information that's being provided in specific fields, and also data completeness. And for communication, we're going to continue all of those communication activities that we're currently doing, and we're also soliciting feedback from stakeholders on communication. And one of the things that we've heard a fair amount is streamlining guidance. And we've heard that it would be helpful to have a one-stop shop for guidance, or as close to that as possible. And so we are working on consolidating and updating our guidance as best we can, and that extends into our website. The guidance website we have has a plethora of information that's been gathered through the years, and we are working on streamlining that to make the information more clear and easily accessible. Oops. Uh-oh.
Oh my goodness.
That's weird.
Oops.
I have no idea what happened there. I must have pressed a really weird button.
Yeah, I think this one.
Oh, it's skipping on its own. Okay. The last piece of the next steps was really just closing out monitoring compliance. And for monitoring, like I said, for the report cards, we're working on releasing them in an Excel format to make them easier to work with. And then we're also working on including more information in them, as well as our additional analyses. And for compliance, I think it's continuing to gather all of the information from the other activities in the integrity plan and working on continuous development of compliance. And I think that that's it for us. We do want to take a moment to thank the people on our teams. We're representing the policy and the operations teams. And while this is a holistic presentation, there's lots of individuals that do an extensive amount of analytical work and policy work and communication leads on our teams. And we just want to acknowledge and thank them for that.
Okay, are there any questions from our in-house audience? If so, please step to the microphone in the center of the room. Okay. Well then, if there are no questions, I would like to thank Monica and Shruti for the update on Encounter data activities. Thank you. Right, if you would like to evaluate this session, go ahead and select A in response to the question. I'd like to evaluate the session. Follow the link, and then respond to the questions that are presented. We will be taking a 60-minute lunch break, and we will begin this afternoon promptly at 12:30. For our in-person guests, please visit the cafeteria downstairs. If you pre-ordered your lunch, you can pick it up right outside the cafeteria at the Jazzman Cafe. And that's it. Enjoy your lunch. We'll see you back at 12:30. Thank you.